my name is Amber Goana and I would like to welcome you to my Med Talk. This is going to be some of the things I pulled from the CPJE California law exam, and as you can see, it's going to be basically like a little Naplex, and so each video is just going to go over each section that I kind of pulled little things from, and I hope you like it. So for this next section, we're going to be going over medications that you're going to use in people who have blood pressure issues. First up here, we have angiotensin converting enzyme inhibitors, also known as your ACEs. They inhibit the conversion of angiotensin 1 into 2, causing vasodilation from a buildup of bradykinin and less aldosterone being released. It is good at protecting the kidneys. It is known to slow the progression in people who have diabetes as well as chronic kidney disease. And it also myocardium from remodeling effects. So people who have some kidney issues, or they're diabetic, or they have some sort of heart issue, you're probably going to be on an ACE. There's lisinopril, Zestaril. It's 10 to 40 milligrams daily with a max of 80 milligrams a day. It is the only ACE inhibitor that is not metabolized. So people who have some liver problems, lisinopril is going to be a pretty good option. You have enalapril, Epadin. It's 5 to 40 milligrams daily or twice a day. It has an IV version that's going to be 1.25 to 5 milligrams every 6 hours. It's 0.625 milligrams initially. If you're on a diuretic and you're trying to start enalapril, they're going to do a pretty low dose of that. There's benzapril, Lotensin, 10 to 80 milligrams daily or twice daily. Captopril, Capotin, 12.5 to 100 milligrams twice daily. Quinalapril, Acupril, 5 to 80 milligrams daily or twice daily. Rampril, Altase, 2.5 to 20 milligrams daily. Fosinapril, Monopril, 5 to 80 milligrams daily or twice daily. And then you have Perinodril, Esion. It's 4 to 16 milligrams daily or twice daily. Some general precautions you want to avoid in patients who are pregnant. Don't be giving them any ACEs. If they have a history of angioedema, and you do not want to re-challenge patients. So in the past, if they had angioedema and you're like, well, you know, that was a while ago, maybe we can try it again. No, actually you cannot. You also want to avoid if it's bilateral renal artery stenosis. Use with other ACEs, ARBs, or Alscritin. You do not want to use with any of those medications together. The dose should be reduced by 50% if a patient is also on a diuretic. It could cause volume depletion, and it could even technically exacerbate heart failure, even though they're kind of put in those patients. Side effects include dry cough. Just because of that buildup of bradykinin, it's going to cause you to have a dry cough. Also, cinoscope, Stevens-Johnson syndrome or TENS, headache. Hyperkalemia is going to cause your potassium to be increased. Renal impairment, if you see their serum creatinine increase by 30% from baseline, you want to DC this medication. You want to monitor the patient's blood pressure, serum creatinine, BUN, and the potassium level. And then we have angiotensin receptor blockers, the ARBs. They reversibly and non-competitively block the angiotensin 2 receptor from binding to angiotensin 1 receptor, causing vasodilation and less aldosterone to be secreted. They only come in tablet formulation. First we have losartan, Cozar. It's 25 to 100 milligrams daily or twice daily. This one can actually lower uric acid levels, so if your patient also has gout, this could be an added benefit for them. Valsartan Diovan is 40 to 320 milligrams daily. Irbesartan Avpro, 150 to 300 milligrams daily. Olmesartan Benicar, 20 to 40 milligrams daily. Candesartan Adcan, it's 16 to 32 milligrams daily or twice daily. If your patient has heart failure, you want to start this candesartan at 4 milligrams daily. You don't really want to start out at 16. This could help prevent migraine headaches. So if your patient has some migraines and also high blood pressure, you could consider putting them on candesartan. There's telmisartan micordis. It's 40 to 80 milligrams daily. And then alzatran and Darby is 40 to 80 milligrams daily. General precautions with all these ARBs, you got to avoid in patients who are pregnant. So just like ACEs and ARBs, do not give to pregnant patients. If they have a history of angioedema, definitely, just like the ACEs, you don't want to re-challenge or nothing like that. You just want to, nope. Rare and occurs in Black patients though with these ARBs. So mostly you're going to see the angioedema in Black population if you see it at all in an ARB. And just like the ACEs, you want to avoid in bilateral renal artery stenosis. Use with other ACEs, ARBs, or alcricin. Just like the ACEs, you don't want to don't be mixing them all together like that. Those should be reduced by 50% if the patient is on a diuretic because of the volume depletion, or if they have heart failure due to a risk of hypotension, just like the ACEs. And these actually could potentially increase lithium levels, which is pretty interesting. So it's just something to be aware of with all the ARBs. Some side effects include orthostatic hypotension. When you stand up too fast, you get dizzy. It could increase your potassium levels. It could cause some renal impairment. So again, you want to monitor that serum creatinine at baseline. If it increases by 30%, you want to DC that drug. It could also cause abdominal pain. You want to monitor the person's blood pressure, serum creatinine, BUN, and potassium levels. Next, we have the dihydropyridine calcium channel blockers. These work by blocking calcium from entering vascular smooth muscles and myocardial cells, which is going to decrease vascular resistance, causing arterial vasodilation. These are actually the more potent vasodilators compared to the non-dihydropyridine calcium channel blockers. These are going to be a little bit more potent. You have amlodipine Norvasc. It's 2.5 to 10 milligrams daily. It is known to cause more peripheral edema. Compared to the other calcium channel blockers, you can see more swelling. Safer option though in patients with reduced ejection fraction and heart failure. It does not need to be kept away from light or moisture. So funny thing, most of these calcium channel blockers, you actually do want to avoid any light or moisture. But this amlodipine, they showed some studies that this one's actually okay to do that. Felodipine extended release, 2.5 to 10 milligrams daily. It's a safer option in patients with reduced ejection fraction and heart failure. So amlodipine or felodipine could be a good option in heart failure. You have nifedipine extended release and immediate release, Procardia. It's 30 to 60 milligrams daily with a max of 90 milligrams. The IR version is not indicated for chronic hypertension, but it is kind of mainly used in pregnancy. That's why they kind of have the IR version. You could see an empty shell in the stool if a patient's on the extended release version of nifedipine. Whenever they defecate, you could see a ghost tablet in the stool. Then we have Nisolidine extended release Solar. It's 17 to 34 milligrams daily. Nicardipine Cardin is 20 to 40 milligrams 3 times a day for the immediate release version. There's also an extended release version. It's 30 to 60 milligrams twice a day. So the IR version of nicardipine can be done 3 times a day, where the ER is going to only need to be twice a day. Whenever you have a patient present with a hypertensive crisis, you can do this nicardipine IV. It's going to be 5 milligrams per hour, but you can increase every 5 to 15 minutes by 2.5 milligrams per hour with a max of 15 milligrams per hour with the hypertensive crisis. This one you definitely want to protect from light during administration is super important whenever they have this hypertensive crisis and you hang in a bag of nicardipine. You want to make sure you have it in a light, sensitive bag. General precautions: you want to caution in patients with aortic stenosis, hepatic impairment, heart failure, can increase concentrations of phosphophenatoin and phenytoin, provides better benefit for patients with Raynaud's syndrome. Side effects include peripheral edema, flushing, headache, tachycardia, palpitations, fatigue, gingival hyperplasia. You want to monitor that peripheral edema, their blood pressure, as well as their heart rate. For the non-dihydropyridine calcium channel blockers, they work by mainly blocking calcium from entering myocardial cells, but they also work on the arterial smooth muscle, which decreases the vascular resistance, causing arterial vasodilation. These have an additive where they also have the ability to control heart rate, which is good to use in patients with supraventricular tachyarrhythmias or AFib. So these non-dihydrocalcium channel blockers, that would be a good option for them. Verapamil, Calin, it's 240 to 480 milligrams daily, usually divided into 2 to 3 doses. It is known to cause constipation and can precipitate heart failure. May leave an empty shell in the stool. So if your patient's taking verapamil, they could see an empty shell, a ghost tablet in their stool. Then there's also diltiazem, cardizem, dosed at 120 to 360 milligrams daily. If you're going to use the IR version, it's only going to be for stable angina. Whenever the patient is getting diltiazem IV, if they have received a beta blocker within the past few hours, you want to make sure you avoid using them that close together. It's going to need a little bit more of a washout period with diltiazem IV. General precautions: you want to avoid use in cardiogenic shock, second or third degree atrioventricular block, sinus rhythm, and heart failure. You want to caution use in hepatic impairment and myasthenia gravis. Some side effects are edema, hypotension, and gingival hyperplasia. You want to monitor their blood pressure, their liver function tests, their ECG, their heart rate, as well as any chest pain. Next up here we have thiazide type diuretics. They work by inhibiting sodium and water reabsorption in the distal tubule and early collection ducts, causing more secretion of potassium, bicarbonate, and magnesium, but less secretion of calcium and uric acid. So if your patient has gout, where it causes that less secretion of uric acid in the kidneys, it's going to cause it to build up. It could precipitate more issues for that patient, so you kind of want to avoid a thiazide. We have HCTZ, which is hydrochlorothiazide. Macrozide is another name for it. It's 12.5 to 50 milligrams daily or twice daily. Chlorothiazide diuryl is 500 to 2,000 milligrams daily to twice daily. Chlorothalidone, cytolone, it's 12.5 to 100 milligrams daily, 1.5 to 2 times more potent than HCTZ. So comparing chlorothalidone to HCTZ, this one's pretty more potent than the HCTZ. So it doesn't really need as high of dosing. That's why it's really daily, where the HCTZ could even be done twice a day. This one's mainly daily. Indapti, Lozil, it's 1.25 to 2.5 milligrams daily. Methylcolosidide, Enduron, is 2.5 to 5 milligrams daily. And then we have metolazone, Xeroxilin, it's 2.5 to 5 milligrams daily. General precautions with all the thiazide diuretics: if your patient has a hypersensitivity to sulfonamides or even penicillin, if they have anuria, have a liver disease, if their creatinine clearance is less than 30, you don't want to be using a thiazide. But metolazone can actually be used in creatinine clearances less than 30. Or if the patient is taking lithium, just where it can cause an increase in drug levels, you don't want to be on a thiazide diuretic. corticosteroid or adrenocorticotropin hormones, just where you have that added water retention, or if the patient's taking dofenyline, methadone, clozapine, or haloperidol because of the QT prolongation additive. It will cause a decrease in cardiac output, and it could also precipitate gout just where it doesn't really cause uric acid to be secreted as much as it usually is through the renal tubules. So for side effects, over time it could cause hypokalemia, so it could cause your potassium levels to be decreased. Acute angle closure glaucoma, it can actually happen within hours or even weeks after you start using a thiazide. You can see that glaucoma start to develop. It can cause hypomagnesia, hyponatremia, photosensitivity, so if you're outside you could get a little more burnt easier. It could aggravate your vertigo and cause Stevens-Johnson syndrome or TENS. You want to monitor blood pressure, urine output, your weight, serum creatinine, your BUN, all your electrolytes, so your sodium, your potassium, your calcium, and your magnesium, your hepatic function, CBC, uric acid, and blood glucose. So you're going to have to be doing a lot of blood tests whenever you're on a thiazide diuretic. Then we have aldosterone antagonists. This competes with your body's natural aldosterone for the receptor sites in the distal renal tubule, causing more secretion of sodium and water, but less potassium. So it's going to cause potassium to be kind of stored, and it's going to help push out more sodium and water. There's eplerenone in PASA. It's 50 to 100 milligrams daily with a max of 50 milligrams twice a day. You want to avoid use in creatinine clearance less than 50 milliliters per minute, or if the patient's serum creatinine is above 1.8 for females, 2 for males. You also want to make sure the potassium level is not greater than 5.5 because it does have an additive where it's going to cause potassium to be kind of held. So if their potassium level is already like 5.5, you don't want to be starting them on aldosterone antagonists. The allopurinol is the least likely to cause gynecomastia. So the man boobs is something you're probably going to develop if you're on one of these, but this allopurinol has the least likely to cause that. There's spironolactone aldactone. It's 25 to 50 milligrams daily. With a suspension formulation, 20 to 75 milligrams daily. It is known to be tumorigenic in rats, so it may not be very good to take if you are pregnant. There's aldactazide, which is a combination of spironolactone and HCTZ. So you got the aldosterone antagonist and a thiazide type diuretic mixed in. It's 50 to 100 milligrams daily of each med. So 50-50 or 100-100. It's known to be also tumorigenic in rats, so just be aware of that. General precautions with all these aldosterone antagonists: avoid in renal insufficiency or liver disease. If your patient has Addison's disease or hyperkalemia, if their creatinine clearance is less than 30, if they're taking lithium or nephrotoxic meds like aminoglycosides, Celastin, or NSAIDs, you want to caution or probably even avoid in that. You don't want to be using with ACEs or ARBs or Alaristin because they all have that increased risk of hyperkalemia. And you want to caution use in patients with gout. Side effects include hyponatremia, hyperkalemia, gynecomastia, vaginal bleeding, decreased libido, so it can decrease your sex drive whenever you're on aldosterone. So you're going to have some man boobs and your sex drive is even going to be lowered. That's not very great at all. It can cause you to have erectile dysfunction. Wonderful. Also headaches. You want to monitor your blood pressure, serum creatinine, BUN, and your electrolytes like your magnesium, your potassium, and your sodium. Next, we have potassium-sparing diuretics. They're going to decrease sodium-potassium ion exchange in the distal renal tubule, lowering the amount of sodium reabsorbed in a cortical collecting duct. It's good for use in patients with thiazide-induced hypokalemia. So if they're experiencing that hypokalemia on a thiazide, you can switch them over to this potassium-sparing diuretic, and it could help increase their potassium. Almoride Medamor, it's 5 to 20 milligrams daily with food. So you want to take almoride with food. Moderic, which is a combination of almoride with HCTZ, so it has the thiazide and the potassium diuretic in it. It's 5-50 milligrams daily with food, with a max of 2 tabs a day. There's triamtrene diridium. It's 100 milligrams twice daily with a max of 300 milligrams a day. Then you have Dizide, which is a combination of triamtrene and HCTZ, which is another thiazide potassium diuretic combo. 3.5-25 milligrams daily, and a max again of 2 tabs a day. General precautions with potassium-sparing diuretics: you want to avoid use in liver disease, stage 4 or 5 chronic kidney disease, if their creatinine clearance is less than 30 milliliters per minute, if their serum creatinine is greater than 1.5 milligrams per 100 milliliter, if their BUN is greater than 30 milligrams per 100 milliliter, or they have acid-base imbalance, you want to definitely avoid use. Also with alcohol or any combo with ACEs or ARBs or alkyricin, because that increase of hyperkalemia. And you want to caution use again with patients with gout. So thiazides, aldosterone antagonists, and potassium diuretics, you just want to caution gout patients. Side effects include photosensitivity, so when they get outside they can be more sensitive to the sun, which was just like the thiazide type diuretics. They're also known to cause diarrhea, hyperuricemia, hyperkalemia, nephrotoxicity, and thrombocytopenia. You want to monitor their blood pressure, urine output, serum creatinine, their BUN, their electrolytes, specifically the potassium, CBC, their uric acid level. Next we have loop diuretics. They inhibit sodium, chloride, and water from reabsorbing in the ascending loop of Henle, causing more secretion of sodium, chloride, potassium, magnesium, and bicarbonate. It is good to use in patients with chronic heart failure as well as peripheral edema, and if their creatinine clearance is less than 30 milliliters per minute, there's a pretty good option for them. There's bumetidine, Bumex, 1 milligram daily hypertension dosing. But if you have a patient with congestive heart failure, edema, nephrotic, they have hepatic syndrome, you can give it PO or IV or even IM. If you want to give it by mouth, it's going to be 0.5 to 2 milligrams in 4 to 5 hour intervals with a max of 10 milligrams a day. That's by mouth. If you're trying to do IV or IM, you can do 0.5 to 1 milligram in 2 to 3 hour intervals with the max still though of 10 milligrams a day. And again, it's for congestive heart failure, edema, some sort of nephrotic or hepatic syndrome. For bumetidine, the IV to PO ratio is 1:1. 1 milligram equals 20 milligrams of torsemide. So bumetidine is actually very potent compared to torsemide. Comparing bumetidine to furosemide, IV wise, 1 milligram of bumetidine is 40 milligrams of furosemide. But by mouth, 1 milligram of bumetidine is 80 milligrams of furosemide. So of the 3 loop diuretics, bumetidine is the most potent. Next up we have furosemide Lasix. It's 20 to 80 milligrams daily or twice a day with a max of 600 milligrams a day. That's by mouth. It can be given IM. It's going to be 20 to 40 milligrams IM. Or you can do a slow IV. The IV to PO ratio for furosemide is 1:2. Next up here we have torsemide, Demodex. It's 5 to 10 milligrams daily for hypertension dosing. And then it's 10 to 20 milligrams daily with a max of 200 milligrams. It can be by mouth or IV for edema with congestive heart failure or renal failure. It is known to cause polyuria, this torsemide, and the IV to PO is 1-to-1, just like bumetanide. Some general precautions with these loop diuretics: you want to avoid use in hepatic coma, anuria, use with lithium or perbenecid, as well as indomethacin or aminoglycosides because of that autotoxicity and the nephrotoxicity. You also want to caution use in patients with sulfur allergies. So loop diuretics and thiazide diuretics you kind of want to avoid in sulfur allergy. Side effects for the loop diuretics include hypotension, hypochloremia, so lowering your chloride levels, as well as hypokalemia and hypomagnesia. It can cause hypercalcemia and hyperuricemia. It can cause dehydration, kidney impairment, metabolic acidosis, Stevens-Johnson syndrome or TENS, encephalopathy, and also photosensitivity, which was just like your potassium sparing as well as the thiazide type diuretics. You want to monitor the patient's blood pressure, urine output, serum creatinine, their BUN, their electrolytes, so their potassium, their sodium, their calcium, and their magnesium, as well as their hepatic function, their CBC, and blood glucose levels. Next up, we have selective beta-1 blockers. They are found in the heart and the kidneys. By blocking beta-1, they're going to decrease heart rate, renin release, and the contractility of the heart in general. There's Baxetil, chlorone. It's 5 to 20 milligrams daily. Atenolol, tenormin, 50 to 100 milligrams daily. But if their creatinine clearance is 15 to 35 milliliters per minute, it has a max dose of 50 milligrams a day. When their creatinine clearance gets less than 15, you want to max that dose out at 25 milligrams a daily. Atenolol is definitely going to be cleared renally. That's why you want to be watching their creatinine clearance. There's bisoprolol, Zybeta. It's 2.5 to 5 milligrams daily if you're treating hypertension, but it's going to be 1.25 to 10 milligrams daily for congestive heart failure. Esmolol Brivolic is 1 milligram per kilogram IV bolus, and then you're going to want to do 150 micrograms per kilogram per minute with a max of 300 micrograms per minute. And you want to avoid use in pulmonary hypertension. Esmolol is not going to be your go-to option if your patient is experiencing pulmonary hypertension, but it is used IV. There's metoprolol tartrate Lopressor. It's 100 to 450 milligrams daily or twice daily by mouth. There is an IV version. You can do 300 milligrams IV bolus, and then 2 milligrams every 2 minutes for 15 minutes. Then after that 15 minutes doing every 2 minutes, you can do 15 milligrams IV. After that, you can do 50 milligrams by mouth every 6 hours for 2 days. You can increase up to 100 milligrams twice a day for 3 months to maybe even years, depending on the patient. And this is going to be for an acute IM. You definitely want to be taking metoprolol tartrate with food. Metoprolol succinate toprolol is 25 to 100 milligrams daily with a max of 400 milligrams a day. That's hypertension dosing. You can do 12.5 to 25 milligrams a day with a max of 200 milligrams a day for congestive heart failure. Again, you want to take with food. So whether you're doing the IR version, the tartrate, or if you're doing the extended release version, the succinate version of metoprolol, you're going to want to take this with food. Last up here we have acetobol, Cetrol. It's 200 to 800 milligrams a day with a max of 1,200 milligrams a day. There is a selective beta-1 blocker with nitric oxide potentiating vasodilatory effects. It's nebivolol, Bystolic, it's 5 milligrams daily with a max of 40 milligrams a day. But if their creatinine clearance gets less than 30 milliliters per minute, or if they have moderate liver disease, their max is going to be 2.5 milligrams daily. You want to avoid use in severe liver impairment. It is known to cause a decrease in your HDL levels, but it could increase your triglyceride levels. It is metabolized by 2D6. That's nebivolol. There's non-selective beta-1 and beta-2 blockers. By blocking the beta-2 receptor, it is found in the lungs, liver, pancreas, and your arterial smooth muscles. So just be aware if your patient has like asthma or something that's affecting the liver or the pancreas, it might not be the best option to use this class. It's propranolol indorol, 40 to 240 milligrams twice to 3 times a day with a max of 640 milligrams a day. This is the IR form. And then there's an extended release form. It's 80 to 160 milligrams daily with a max of 640 milligrams a day. Propranolol is good to use for tremors or migraine prophylaxis. It is a P-glycoprotein inhibitor though, so just be aware of that. There's timolol blocardin. It's 10 to 30 milligrams twice a day. Naldol Corguard is 5 to 30 milligrams twice a day. This one's also renally secreted. So remember, atenolol was 100% renally secreted. And the last option here we have is Panadol Visican. It's 5 to 30 milligrams twice a day. One more class is non-selective beta blocker as well as alpha-1 blocker. These are known to cause edema as well as increase your triglycerides but decrease your HDL levels, which was just like nebivolol Bystolic. You want to make sure you avoid in hepatic impairment 100%. Do not use these medications in that. The examples are carvedilol Coreg. It's 6.25 to 25 milligrams twice a day. That's the IR version. And then you have the extended release version. It's going to be 20 to 80 milligrams a day. You want to make sure you take this with food. So just like metoprolol, with food. And it is a P-glycoprotein inhibitor, which was just like propranolol. Then there's labetalol trinidate. It's 100 to 2,400 milligrams twice to 3 times a day by mouth. There is an IV version. You can do 20 to 30 milligrams given at 40 to 80 milligrams every 10 minutes with a max of 300 milligrams daily if you're trying to give labetalol IV. General precautions for all the beta blockers. They are good to use in patients with myocardial infarction or heart failure. You definitely don't want to just all of a sudden DC the medication. You want to make sure that you taper off the patient because it can cause angina pectoris and even a myocardial infarction or ventricular arrhythmias, as well as rebound hypertension if it's DC just all of a sudden. You don't want to use in cardiogenic shock patients, 2nd or 3rd degree atrioventricular block patients, or if they have sinus bradycardia. They are also known to mask signs and symptoms of hypoglycemia, as well as reduced insulin secretion, which can cause hyperglycemia. So if your patient is diabetic, these beta blockers kind of don't really allow them to notice the signs and symptoms of hypoglycemia. And with that insulin release reduced, it's going to cause hyperglycemia. So it just might not be the best option for diabetic patients. You want to caution use with clonidine, calcium channel blockers, because of that additive bradycardia effect, as well as diltiazem and verapamil, because of the additive decrease in heart rate. Some general side effects include depression, lower your heart rate, as well as decreased libido, which was like the aldosterone ones. You want to monitor blood pressure, heart rhythm, heart rate. It will need to be decreased if their heart rate gets less than 55 beats per minute. You want to decrease that dose, as well as monitoring their shortness of breath. And that's all I got for you for all the blood pressure medications. Again, my name is Amber Gawana, and I wish you the absolute best in all your studies.